Hello friends, let us discuss this very important topic of deep neck spaces. Very important because a lot of questions are asked from these spaces. Okay, so in every exam you will find at least 1 to 2 questions which have been asked from these deep neck spaces, right? So let us look at the first space, the superficial space. Now the superficial space, this space is along the entire length of the neck. So remember, in the previous topic we discussed about the different cervical fascias, different layers. Now we had a layer that was known as superficial layer of cervical fascia. Now the superficial layer of cervical fascia was just below the skin, okay, it was above the platysma, right? So now this layer, okay, this layer, it does not have any boundaries. It is all along the head and the neck region, okay, and that layer you see, I am highlighting that layer just below the skin. Over there we can have an abscess formation, okay, it will be a diffuse abscess, right? So this is known as the superficial space. Remember, all these spaces that I am talking about are potential spaces. They are not true spaces, they are potential spaces. So actually they are not present, but if there is an infection, there is an abscess formation, then they will appear as a space. Okay, so this is the superficial space and it is not very significant for us. We will be talking about the deep neck spaces. Okay, so that means those spaces are formed by the deep layer of cervical fascia. So deep layer of cervical fascia, if you remember, is divided into 3 more layers: superficial layer, middle layer and deep layer. All right, so we come to the deep neck spaces, and these deep neck spaces can be divided into 4 different categories. Okay, the first category is those in the face. So in the face we have number 1 the buccal space, number 2 the canine space, number 3 the masticator space, and number 4 the parotid space. We are going to discuss each one of them one by one. Okay, then we have the spaces which are above the level of hyoid bone. So in the suprahyoid neck we have 3 spaces. The peritonsillar space, remember the peritonsillar space, we have already discussed this space along with the tonsils, between the tonsil and the tonsil capsule and the superior constrictor muscle. Then we have the submandibular space and we have the lateral pharyngeal, also known as parapharyngeal space. Okay, now below the hyoid bone we have the space known as anterior visceral space, and then finally along the entire length of the neck we have the spaces which we already discussed in the previous topic. We will discuss them again, and those are the retropharyngeal space, the danger space, the prevertebral space and the carotid sheath space. So I have enumerated all the different spaces. Okay, so we will discuss each of these spaces one by one. Now before we start with the spaces, let's remember all these spaces are potential spaces. They become space when there is an infection, and the most common source of infection is the dental infection. Okay, so whenever the tooth have the cavity, now from this cavity the infection goes into the pulp of the teeth, and from there it goes to the roots, to the apex. Okay, thereafter it forms an abscess, a periapical abscess. This is known as a periapical abscess. This can further spread. Look over here, this periapical abscess can further spread and it can form different kinds of abscess. Okay, so the most common source for these deep neck space infections or the abscess is the dental infection, right? Now let us start with the first space, spaces in the face, and we are starting with the first space, that is the buccal space. Now remember the superficial layer of deep cervical fascia. So we discussed the superficial layer of deep cervical fascia, it extends up. Okay, so now look in the face, what do we have? We have the buccinator muscle. Okay, so we have the buccinator muscle. Now this is not a true muscle of mastication, it is actually a muscle of facial expression, but it also helps in mastication by pushing the food back into the oral cavity, otherwise it will be lying between the cheek and the teeth. So this buccinator muscle is an accessory muscle of mastication. That's an accessory function. Okay, somebody asks you which are the muscles of mastication. We know masseter, we know pterygoids, medial pterygoid, lateral pterygoid, and we have the temporalis. So we'll come to that, but this is a muscle of facial expression. Now this muscle is covered by the superficial layer of deep cervical fascia. Okay, so between the buccinator muscle and the superficial layer of deep cervical fascia, we have a space formation that is known as buccal space. Okay, so the buccal space is formed between the buccinator muscle and superficial layer of deep cervical fascia. Okay, superficial layer of deep cervical fascia. There we have the buccal space. Now look in this diagram, what else can you see? You can see the parotid duct, you can see the pterygomandibular raphe. Remember, behind the pterygomandibular raphe, from here originates your superior constrictor muscle. Okay, that is to orient you to this anatomy. Okay, now see over here, the infection from the tooth. You can see the buccinator muscle and the infection from the tooth, it goes lateral to the buccinator. So you can see that this over here, this is the skin, and then we have the superficial layer of deep cervical fascia over here, and between the buccinator and the superficial layer of deep cervical fascia, an abscess is formed. So that is a buccal space abscess. This abscess will appear in the cheek over here. Okay, so that is your buccal space. Let's come to the next space. The next space is the canine space. Right? Now this canine space is formed in the canine fossa. So it is formed over here in the canine fossa, that is in the anterior wall of the maxilla. In the anterior lateral wall of the maxilla, it is covered by different muscles. You see, there are a lot of muscles of facial expression. Now in between them, a small gap is created at the canine fossa, and that space may get infected, especially when the canine tooth infection reaches up and forms a periapical abscess. Okay, so that forms a canine space abscess. Let's look at the muscles. We can see the zygomaticus major, which forms the lateral boundary of the canine fossa. Okay, and then we have the levator anguli oris, we have the zygomaticus minor, we have over here the levator labia superioris and levator labia superioris equinasi. So in between them, you can see over here, we have a space over here. Now that is your space which posteriorly communicates with the buccal space. So that is your canine space. Right? You can also see the orbicularis oris over here, that helps in opening and closing of the mouth. So this is the canine space. An infection in the canine tooth can lead to formation of an abscess over here. That's a canine space abscess. Okay, let's come to the masticator space. We have already talked about the masticator space in the previous topic when I was describing you the superficial layer of deep cervical fascia. So this masticator space, as I told you earlier, is divided into three spaces. Which are those three spaces? Masseteric space, okay, pterygoid space, and temporal space. Right? So the masticator space consists of these three spaces. Remember, what are the masticatory muscles? The masticatory muscles are, we can see in this diagram, we have the ramus of mandible. On the lateral aspect to it, we have the masseter. Okay, and the masseter is attached to the zygoma over there, you can see that. Then we have the temporalis muscle. Right? Okay, the next we can see the medial pterygoid muscle, and we can see the lateral pterygoid muscle. Now, MCQ questions. Out of all the masticatory muscles, only one muscle, okay, the lateral pterygoid, this is the depressor muscle. It opens the jaw. Okay, so I remember it as LD. LD, lateral depressor. Okay, all the remaining muscles, they are elevators of the jaw. Okay, so all of them are the elevators of the jaw. The next question, what is the nerve supply? So remember the masticatory muscle. So we discussed this in the earlier part in the first topic, the derivatives of the branchial arches. So all these masticatory muscles, they are derived from the first arch. Okay, what is the first arch? The first arch is the mandibular arch. Right? So they are derivative of the first arch, the mandibular arch. Therefore, all of them are supplied by the first arch nerve, that is the mandibular nerve, cranial nerve V3. Okay, all of them are supplied by cranial nerve V3. The buccinator muscle is the muscle of facial expression. So primarily it's a muscle of facial expression. It is not a primarily masticatory muscle. It is an accessory masticatory muscle. It is derived from the second arch. It formed from second arch. Therefore, it is supplied by a facial nerve. So no confusion. Okay, it is not a muscle of first arch. It's a muscle of second arch. Okay, now you can now see the nerve supply. You can see the different muscles. Now another question that is asked, suppose there is a masticatory space abscess. Now where will be the abscess? You see, the abscess will be once again in the face. Okay, the abscess is once again in the face. So how will I differentiate a masticator space abscess from a buccal space abscess? How can I differentiate both? Both of them are on the face. Okay, how do I differentiate? Now remember, the masticator space abscess is around the masticatory muscles. These masticatory muscles will undergo spasm. Okay, they will undergo spasm. If they undergo spasm, they will lead to trismus. So trismus is a characteristic finding in the masticator space abscess. Remember, this question is asked, you are given a clinical question, okay? This is the trend. Now in the next exam, we will get only clinical questions. So a clinical question is given to you about a patient who's having fever, there is a swelling on the face, okay? Fever, swelling on the face. Now in the question, it is mentioned patient has trismus. Patient has what? Trismus. So there is a swelling on the face, patient has trismus. So which space it is? It is masticator space abscess. Okay, trismus points towards masticator space abscess because it is because of the spasm of the masticatory muscles. Right? Clear? Okay. Next, let's look over here. We have the foramen ovale. So remember, from the foramen ovale comes out the mandibular nerve. Foramen ovale, I hope you remember the mnemonic. We studied that in the nose also. Mandibular nerve, accessory meningeal artery, lesser petrosal and MS3 vein. Okay, so mandibular nerve V3, accessory meningeal artery, okay, lesser petrosal nerve and MS3 vein. Male is the mnemonic, structures passing through foramen ovale. Right? Okay, let's look in this axial cross section. In this axial cross section, you can identify the ramus of mandible. Now around that ramus of mandible, you can see the masticatory muscles, and around them we have the masticatory space. Okay, so remember, these muscles, they are covered by superficial layer of deep cervical fascia. So between the fascia and the muscle tissue, we have the space known as masticator space. Okay, next space in the face is the parotid space. So I told you there are 4 spaces in the face: buccal space, then we discuss the canine space, then we discuss the masticator space, and the last space in the face is the parotid space. Now remember, parotid again is covered by the superficial layer of deep cervical fascia. Remember, I told you the superficial layer of deep cervical fascia, it condenses and forms the capsule of the parotid gland. Okay, so this encloses a space between the gland tissue and the fascia, or the capsule, that is known as parotid space. Right? Okay, so you can see the parotid gland over here. Now let's come to the cross section. So this is again an axial cross section. What can you see in this axial cross section? You can see the parotid gland. Okay, now you see this parotid gland is enclosed between different other structures. What are the structures? You see over here, you can see anteriorly we have the mandible. That's the ramus of the mandible, and the mandible On the lateral aspect of the ramus, we have the masseter. On the medial aspect, we have the medial pterygoid attached to it. Right? Okay. Now, remember, we have also the palatine tonsil. So this is the pharynx, the oropharynx. You can see the palatine tonsils, and the palatine tonsils, they are laterally, the bed is formed by the superior constrictor muscle. So you can see the bed of palatine tonsils, that is the superior constrictor muscle. Now behind the parotid, you can see the sternocleidomastoid muscle. Right? So these are the structures, important structures. See the posterior belly of digastric in the posterior aspect of the parotid. So these are the important structures which are there in the relation to parotid. Now the most important relation is on the deep aspect. So we see the parotid, it has a superficial lobe, it has a deep lobe. Now deep to the deep lobe, that is medial to deep lobe, we have a space. That space is known as parapharyngeal space or lateral pharyngeal space. We will be discussing about this space shortly. Okay, right? So we'll discuss about this space in some time. Before we discuss that, let us study a little bit more about this parotid anatomy and the parotid space. So what do we see in this diagram? We can see the parotid gland. Okay, we can see the parotid gland. This is the skin. Let's go layer by layer. We see the skin. Now just below the skin, we have the superficial fascia. Okay, then below that superficial fascia, we have the platysma. Right, these are the layers that a surgeon must know for operating the parotid gland. So we have the platysma. Now below the platysma, you have the parotid fascia. Remember, parotid fascia is formed by the superficial layer of deep cervical fascia. Okay, now what else do you see? Now below this parotid fascia, you have the lymph nodes. So these are actually the intraparotid lymph nodes because they are inside the capsule, and they may also undergo swelling. They may form a parotid space abscess. So these are lymph nodes over here, and they can enlarge, they can form a parotid space abscess. Okay, right. Now you can see the parotid gland is divided by a nerve, the facial nerve, going from posterior to anterior. You can see the facial nerve. This divides the parotid gland into two lobes. Which two lobes? Superficial lobe and deep lobe. Now I hope you remember we discussed this in the ear. When we discuss about the facial nerve, we discuss that the parotid is divided into two parts, superficial lobe and deep lobe, by the facial nerve. Right? Okay, remember that's the mastoid process. So facial nerve comes out of there and it goes anterior. We can see over here the ramus of mandible. Now in the deep lobe, you can also see the structure such as the retromandibular vein, and you can see the external carotid artery. Okay, deep to that, there are other important structures. We will be talking about them shortly. Right, so that is the parotid space and the parotid anatomy, very important for us for doing the surgery. Okay, right, let's go and discuss the other deep neck spaces. Now before we do that, let us understand this diagram. This one single diagram will help us understand all the remaining neck spaces. Okay, so with the previous knowledge of the cervical fascia, we are going to study this diagram. Now let me orient you to this diagram. Okay, we have the cervical vertebra. All right, so that is the C2 cervical vertebra in the neck. Okay, that is the posterior aspect. The anterior aspect, we have the oral cavity. Okay, behind the oral cavity, what do you have? You have the oropharynx. Right. Okay, now what is there in the oropharynx? In the oropharynx, you have the palatine tonsils. Okay, pair of palatine tonsils, one on each side. This we have studied. Right? Okay, now the bed of this palatine tonsils is formed by superior constrictor muscle. So you can see that superior constrictor muscle from both the side goes and fuses posteriorly in the midline raphe. Right? Okay, this also we have studied. Now most of the things we have studied, we are just culminating them into one place. Now Between the capsule of the palatine tonsils and the superior constrictor muscle, there is a space over here. So you see, I have marked this space. Okay, so this space over here, this is known as peritonsillar space. Remember, infection of this peritonsillar space, this is known as peritonsillar abscess, also known as quinsy. Okay, so this is also known as quinsy. Now, what happens in quinsy? What happens in quinsy? In case of quinsy, you see, in case of quinsy, the tonsil is red and large congested. Okay, the tonsil is red and large congested, and it may even reach the midline. Right? Tonsil is red and large congested, it may even reach the midline. So that is your quinsy. Right? Okay, let's go ahead. Let's look at this fascia. Now, surrounding the superior constrictor muscle, we have the fascia, which is known as buccopharyngeal fascia. Right? So this fascia is known as buccopharyngeal fascia. That also we have studied earlier in different places. Okay, now we have the cervical vertebra. Now, just anterior to the cervical vertebra, we have the fascia that is known as prevertebral fascia. Okay, so that fascia is known as prevertebral fascia. Now, between the prevertebral fascia and the cervical vertebra, we have the space. We know that space is known as prevertebral space. Right? This we studied. Now, anterior to prevertebral fascia, we have the alar fascia. Remember, between the alar fascia and the prevertebral fascia, we have the space. This space is known as danger space. Right? Okay. Now, the buccopharyngeal fascia. Look at the buccopharyngeal fascia. Between the buccopharyngeal fascia and the alar fascia, there is a space. This space is known as retropharyngeal space. Okay, this space is known as retropharyngeal space. Now, before I go ahead, let's understand one thing. Suppose there is a prevertebral space abscess. Okay, let me go back. Let's say there is a prevertebral space abscess. Right? Okay, now what will happen? This prevertebral space abscess, where will be the abscess? You see, this abscess is over here in the posterior pharyngeal wall. So all these are important MCQs which I am telling you. So we have a prevertebral space abscess. The abscess will appear in the posterior pharyngeal wall. Right? Where? In the midline. You see, it will appear in the midline. A prevertebral space abscess appears in the midline. Right? Okay. Now, let's say we have a retropharyngeal space abscess. Okay, so we can see this retropharyngeal space. Now, let's say we have a retropharyngeal space abscess. Where will be the retropharyngeal space abscess? Again the space abscess will be in the posterior pharyngeal wall. But look carefully. When you look carefully, what do you see? This abscess will be in the posterior pharyngeal wall, but it will not be in the midline. It will be on one side. Why? Why one side? You see, look carefully and you will notice that the buccopharyngeal fascia, it fuses with the alar fascia in the midline. You see over here, it fuses with the alar fascia in the midline. Therefore, it forms two retropharyngeal space, one on left side and one on right side. Okay, so there are two retropharyngeal spaces formed, right and left. Okay, so therefore, if the abscess is there in the retropharyngeal space, it will be on one side of the posterior pharyngeal wall. A prevertebral space abscess will be in the midline. Okay, that is important question asked in the MCQs. Right? This is an important question, how to differentiate a prevertebral space abscess from a retropharyngeal space abscess. Prevertebral space is in the posterior pharyngeal wall midline. Retropharyngeal space abscess is on one side of the posterior pharyngeal wall. right? Okay, now let's go ahead. Now we have discussed the anterior posterior. Let's go lateral. Let's go to the side. So what do we see on the side? On the side we can see the parotid gland. We were just talking about the parotid, we can see the parotid gland. Okay, now anterior to parotid you can see the ramus of mandible, and you can see the muscles attached to it, the masseter and the medial pterygoid. Lateral aspect masseter, medial aspect medial pterygoid. Right? Clear? Okay. Now you see this space between the pharynx, between the oropharynx, okay, lateral aspect of pharynx and these structures. This is known as parapharyngeal space or lateral pharyngeal space. Okay, so this is known as parapharyngeal space or lateral pharyngeal space. Right? Parapharyngeal space or lateral pharyngeal space. Let's see the boundaries of parapharyngeal space. Shall we? Yes, we can see the boundaries of parapharyngeal space. So what is there on the lateral aspect? What is there on the lateral aspect of parapharyngeal space? On the lateral aspect, number one, you see deep lobe of parotid gland. Okay, so you see there is deep lobe of parotid gland. What else do you see? You see the medial pterygoid and you see the ramus of mandible. Right? So there is ramus of mandible, and on it we have the attachment of medial pterygoid muscle. Okay, so that is the lateral boundary of parapharyngeal space. Now what's there on the medial boundary? What is there? On the medial boundary you can see that there is buccopharyngeal fascia. Right? Clear? That is quite evident. We have over here the buccopharyngeal fascia. Okay, anything else? You see this buccopharyngeal fascia, number one, and it is supported by what? We have the superior constrictor muscle. And then what else do we have? On the medial aspect, we have the palatine tonsils. Okay, we have the palatine tonsils, and superiorly, what we cannot see over here, we also have the soft palate. So these structures, they form the medial aspect, medial boundary of parapharyngeal space. And what is there in the posterior boundary? So you see carefully, in the posterior boundary, we have the prevertebral fascia. Okay, so we can see this prevertebral fascia. This forms the posterior boundary of the parapharyngeal space. Right? Okay, so these are the boundaries of parapharyngeal space. Now, this parapharyngeal space, okay, this parapharyngeal space, it is an inverted pyramid. It's an inverted pyramid, right? This parapharyngeal space is an inverted pyramid. The base of the pyramid lies at the skull base. It lies at the skull base. The tip of the pyramid, it lies at the hyoid bone. Okay, so it's an inverted pyramid. The base lies at the skull base. The tip lies at the hyoid bone. It's an inverted pyramid. Okay, now let's look at this. Let's look inside the parapharyngeal space, shall we? Yes, so we look inside the parapharyngeal space. What all structures can we see inside the parapharyngeal space? Now, inside the parapharyngeal space, you can see the styloid process. Okay, can you see the styloid process? Yes, I have highlighted it. We can see the styloid process. Now, surrounding the styloid process, there are muscles and ligament which arise from the styloid process. They go up till hyoid. So we have muscles and ligament around the styloid process. I have encircled them, and together they are known as styloid apparatus. Okay, so together these are known as styloid apparatus. Now, this styloid apparatus divides the parapharyngeal space. Okay, so it divides the parapharyngeal space into two parts. The anterior part is known as pre-styloid compartment. So that is your anterior compartment or the pre-styloid compartment. Okay, and then we have the posterior compartment or the post-styloid compartment. Okay, so we have the pre-styloid compartment and the post-styloid compartment, right? Anterior to the styloid and posterior to styloid. Now, what is there in the pre-styloid compartment? Pre-styloid compartment, we have fat, adipose tissue, and we have lymph nodes. Okay, so we have fat and lymph nodes in the pre-styloid compartment. What is there in the post-styloid compartment? In the post-styloid compartment, you can see important neurovascular structures. Which important neurovascular structures? You can see the IJV, internal jugular vein. You can see the internal carotid artery, right? You can see the different cranial nerves. Which cranial nerves? 9th, 10th, 11th, 12th, and we also have the sympathetic chain. Okay, so all of them are present in the post-styloid compartment, right? So important neurovascular structures are there in the post-styloid compartment of the parapharyngeal space. Okay, right, clear? Now, let's say there is a parapharyngeal space abscess. Okay, there is a parapharyngeal space abscess. Now, what will happen because of this abscess? This abscess, when it forms, it will spread, and what will happen? It will push this abscess will appear on the lateral pharyngeal wall. You see, this abscess, the space is lateral to the pharynx, so this abscess will also appear on the lateral pharyngeal wall. All right, and it will push the tonsils. You see, it will push the tonsils to midline. Okay, so it will push the tonsils to midline. So now, you see, there are two questions. Patient has fever, pain in throat. Okay, patient comes to you with complaint of fever, pain in throat. Now, this is very important. These questions have been repeated multiple times. So, patient has fever, pain in throat. On examination, you find that the tonsil is red, enlarged, congested. So, tonsil itself is enlarged. Answer is quinsy. Okay. Now, if the question says there is a swelling in the lateral pharyngeal wall pushing the tonsils to midline. So, tonsils have not come to midline on their own. They have been pushed to the midline. That means it is a case of parapharyngeal abscess. Okay. So, in simple words, the mentioned is question, in the question it is mentioned tonsils pushed to midline. Answer is parapharyngeal space abscess. If it says tonsils are enlarged and they reach midline, so that means they are reaching on their own. So they are enlarged, they reach midline. Answer is quinsy. Very, very simple language. Just remember, somebody pushes you, that means the force is applied by the person behind you. If you reach yourself, okay, that means there is something within you, right? So within, that means quinsy, okay, push from behind, parapharyngeal space abscess. Clear? Okay, right. Good, nice. Let us look little bit more into this parapharyngeal space. So I told you parapharyngeal space has two components, anterior component and posterior component. Okay, anterior component is the pre-styloid compartment. Okay, posterior component is the post-styloid compartment, and it has important neurovascular structures. Right, we saw that. Okay, let's say there is an isolated abscess of the pre-styloid compartment. There is an isolated abscess of the pre-styloid compartment. Now, what is there in the pre-styloid compartment? In the pre-styloid compartment, the lateral aspect, we have the medial pterygoid muscle. If this muscle is irritated, patient will have trismus. Okay, so that means the parapharyngeal space abscess, it can involve the medial pterygoid. Medial pterygoid is a masticatory muscle and it can cause trismus. Okay, right? It can cause trismus. So trismus is seen in parapharyngeal space abscess, but which part? In the pre-styloid compartment. The post-styloid compartment, that is away from the medial pterygoid. So therefore, an abscess of the post-styloid compartment will not have trismus. Trismus is a characteristic of anterior compartment abscess. Right? Clear? Good. Okay. Suppose there is a quinsy, peritonsillar space abscess. Over here we have quinsy. Now this quinsy, where it can spread? It can go to the parapharyngeal space. Which parapharyngeal space? It will of course go to the anterior compartment that's right next to it. Okay, so right next to it we have the parapharyngeal space, pre-styloid compartment. If it goes there, it can even go to the medial pterygoid. It can cause a spasm. So remember, medial pterygoid, it has entered into the masticator space. Now medial pterygoid is undergone spasm. Patient has trismus. So if a patient has quinsy, okay, a quinsy patient may spread to parapharyngeal abscess. Okay, the quinsy can spread to parapharyngeal space. It can form a parapharyngeal space abscess and it can cause trismus. This is again because of involvement of medial pterygoid muscle. Okay, so as I was telling you, medial pterygoid muscle is the most common masticatory muscle which is causing trismus. Okay, so there may be situation where other muscles are causing trismus or all of them are causing trismus, but most important is the medial pterygoid. Parapharyngeal space, medial pterygoid is involved. Quinsy, once again it involves the parapharyngeal space and then it involves the medial pterygoid. So again the abscess can cause trismus because of involvement of medial pterygoid muscle. Clear? Okay, let's go ahead. Since we are discussing this space, let's remember that the lateral boundary of the parapharyngeal space is formed by deep lobe of parotid gland. So if there is a parotid gland tumor, okay, there is a parotid gland tumor of the deep lobe. Now where will that tumor grow? So let's say there is a parotid gland tumor over here, and where will this tumor grow? This tumor will grow and it will occupy the parapharyngeal space. Okay, again it may appear in the lateral pharyngeal wall. Right? So this question has also been asked, where will you see the deep lobe of parotid gland tumor? So you will see that tumor in the parapharyngeal space. Okay, the superficial lobe of parotid gland tumor will appear over here just below the earlobe. Okay, so just below the earlobe, it will push the earlobe up, right, laterally and up. A superficial lobe of parotid gland tumor will push the earlobe laterally and up, whereas a deep lobe of parotid gland tumor, it will appear in the parapharyngeal space and it may also appear in the lateral pharyngeal wall. Clear? Okay, so this question has also been asked. Okay, right? So this was the diagram that I wanted to discuss, and it discusses most of the spaces of the deep neck. Let's go forward and look at each of these spaces individually. Okay, so we have till now discussed the spaces in the face. There were 4 spaces that I discussed. Which were those 4 spaces? Number 1, we discussed the buccal space. Number 2, we discussed the canine space. Number 3, we discussed the masticator space. Number 4, we discussed the parotid space. Okay, now we come to the spaces above the hyoid. So spaces in the neck above the hyoid, number 1 is the peritonsillar space. Okay, that we have already discussed along with the tonsils. Then the space above the hyoid is the parapharyngeal space. Okay, the parapharyngeal space, as I just discussed, it is a inverted pyramid. So you can see I have drawn an inverted pyramid. Okay, the inverted pyramid starts from the skull and it ends at the hyoid bone. Right, this parapharyngeal space, you can see we can have a cross section over here. So once we have a cross section, this is the cross section we just discussed. This is the parapharyngeal space. The lateral aspect is formed by the parotid gland and the ramus of mandible and medial pterygoid. The medial aspect is formed by the we have the buccopharyngeal fascia that is supported by the superior constrictor muscle, the palatine tonsil and the soft palate, whereas the posterior aspect is formed by the prevertebral fascia. So we have discussed all this cross section already. Okay, now we can also do a cross section in the anterior aspect of parapharyngeal space. Very important point that I wanted to show you, that these deep neck spaces, they all communicate with each other. So you see in the anterior aspect, the parapharyngeal space, it may spread to the submandibular space. So you see this space over here, this is the submandibular space. So in the anterior most aspect, the parapharyngeal space can even spread to submandibular space. Right? Okay, now let's take a cross section in the posterior aspect. So this is the posterior aspect of the parapharyngeal space. Right till the apex, I have taken a cross section. You can see over here the hyoid bone. So this is the tip of this pyramid. You see, this is the tip of the pyramid. So the parapharyngeal space, it ends at the hyoid bone. So we have discussed this space already in detail, right? Let us now discuss the submandibular space. Okay, now the submandibular space, remember we had the superficial layer of deep cervical fascia. It was covering the submandibular gland. So between that fascia and the mucosa of the floor of mouth, okay, so mucosa of the floor of mouth and the superficial layer of deep cervical fascia, we have a space over here that is known as submandibular space. Okay, so this space between the mucosa and the superficial layer of deep cervical fascia, this is known as submandibular space. Now this submandibular space, okay, you see in this submandibular space, we have a muscle, the mylohyoid and the genohyoid. Okay, let's look in this view. We can see the mylohyoid muscle and the genohyoid. Now you see the mylohyoid muscle. You see this mylohyoid muscle, okay, starting from the mandible to the hyoid bone, the mylohyoid muscle, it divides the submandibular space. You see, this mylohyoid muscle, it divides the submandibular space. Right? The part of this submandibular space above the mylohyoid is known as sublingual space. It is just below the tongue, so sublingual space. And the space below the mylohyoid is known as submylohyoid space. Okay, so below the mylohyoid is known as submylohyoid space. Now what is there in the submylohyoid space? What is there? What do you see over here? What is this? What is this? This is the submandibular gland. Okay, so we can see the submandibular gland. What else do we have? We have fat, we have lymph nodes, fat and lymph nodes, that is there in the submylohyoid space. Now what is there in the sublingual space? What is there in the sublingual space? You can clearly see over here, we have the sublingual gland. That's clearly visible. We have the sublingual gland. What else can we see over here? You see over here a duct is coming from the submandibular gland. Which duct? We have the Watson's duct. So we have the Watson's duct. You can see it is coming from the submandibular gland. So you can see a part of submandibular gland, this tail of submandibular gland, it curves around the posterior border of mylohyoid and it comes in the sublingual space. Okay, let's take a closer look over here. You can see that this submandibular gland, the tail of this submandibular gland takes a turn at the posterior border of the mylohyoid muscle and now it appears in the sublingual space. From here you can see that the Watson's duct, the submandibular gland duct is originating. Right? Okay, so that is there. Now what else is there in the sublingual space? Now in the sublingual space, other than that, we also have the lingual artery. Okay, so we also have the lingual artery over here. You can see that this is the lingual artery. Okay, we have the lingual artery. Then we have two nerves, two important nerves. Which nerves? We have the lingual nerve and we have the hypoglossal nerve. Okay, so we have the lingual nerve and the hypoglossal nerve. They are present in the sublingual space, right? Okay, so these were the contents of submandibular space. An infection of this space, of the submandibular space, is known as Ludwig's angina. What is Ludwig's angina? Ludwig's angina is a rapidly spreading cellulitis. It is not an abscess. Remember, it is a rapidly spreading cellulitis of submandibular space. Okay, so if a frank pus is there, that will be known as submandibular space abscess. Now, in Ludwig's angina, we don't have frank pus formation, but the soft tissues, the subcutaneous tissue is swollen. So that is known as cellulitis. And Ludwig's angina is a rapidly spreading cellulitis of the submandibular space. Right? Remember when I was teaching you tonsils, the membrane over tonsils, I taught you over there Vincent's angina. And there I took this name Ludwig's angina and I told you that this is not at all related to tonsils. Okay? Right? Remember that this space, this Ludwig's angina is an infection of the submandibular space. Right? Rapidly spreading cellulitis of submandibular space. Now, remember, this Ludwig's angina, look at this anatomy. Look at this anatomy. What do you see? You see that if there is an infection over here, okay, it's a rapidly spreading cellulitis. It can go and it can quickly spread to the airway. You see, this can quickly spread to the airway and therefore it can cause respiratory obstruction. If the swelling increases, it can go and block the respiratory pathway. Okay, so therefore, this has to be treated with urgency. The Ludwig's angina has to be treated with urgency. And what do we need to do? Number one, we need to do incision and drainage. Yes, there is no pus. Still we give incision. Okay, why do we give incision? We give incision so as to open up the space, right, and to release the pressure. And there may be some fluid, it's not a pus, there may be some fluid that may come out, okay. So some serous fluid comes out, but it is mainly to release the pressure, okay. What else do? We give IV antibiotics, okay. We give IV antibiotics. Anything else other than this? We may also have to do tracheostomy. Most of these patients, they are undergoing respiratory obstruction because of the pressure. So you may also have to do tracheostomy to save the airway of these patients. Otherwise, they may collapse, the airway may collapse and patient may die. Okay. So Ludwig's angina may also need a tracheostomy, right? Now, let us go ahead and discuss the space below the hyoid. So below the hyoid, we had only one space, that is the anterior visceral space. Now this, remember, the middle layer of deep cervical fascia. Okay, the middle layer of deep cervical fascia. Now this middle layer of deep cervical fascia had two parts, the anterior part, the muscular division, and the visceral division. Okay, now the visceral division, it continues into the mediastinum and it forms a space over here that is known as anterior visceral space. Okay, so this space is known as anterior visceral space. It has lymph nodes. Sometimes it may get infected because of the lymphadenopathy and there may be formation of abscess over here. Right. Now lastly, we come to the spaces along the length of the neck. And these spaces we have already discussed. Remember, we discussed it multiple times. Just for revision, I am telling you, anterior to vertebra, we have the prevertebral fascia. Okay. Anterior to the prevertebral fascia, we have the alar fascia. And anterior to the alar fascia, we have the buccopharyngeal fascia. Right? Okay. So between the vertebra and the prevertebral fascia, we have the prevertebral space. Right? Along the entire length of the vertebral column, we have the prevertebral space. Then between the prevertebral fascia and the alar fascia, we have the danger space. So danger space extends from skull base to the diaphragm. Okay. Why it is known as danger space? Because any infection that enters into danger space will be taken to the mediastinum. So it will cause mediastinitis. Then between the alar fascia and the buccopharyngeal fascia, we have the retropharyngeal space. Remember, because the alar fascia and the buccopharyngeal fascia, they fuse, therefore this retropharyngeal space is divided into right retropharyngeal and left retropharyngeal. Okay, that part also we have discussed. Right? So these are the spaces along the entire length, but this will not finish with the last space, that is the carotid sheath space. So this space is also along the entire length, and as we discussed earlier, the carotid sheath is formed by the contribution of all the three layers of deep cervical fascia. What is there inside the carotid sheath? Inside this carotid sheath, inside this we have the internal jugular vein, we have the ICA, and we have the 10th cranial nerve, that is the vagus. Okay. Once again, if an infection enters into the carotid sheath, it will also be taken to the mediastinum and it can cause mediastinitis. In fact, this carotid sheath space, okay, it acts like a highway. So this is known as Lincoln's highway. So this space is known as Lincoln's highway, the carotid sheath space, right? And this also runs along the entire length of the neck. So these were the different spaces that I wanted to discuss and tell you. Okay, now before we finish, let us discuss a few MCQs. First question asked in the DNB June 2018 exam, Ludwig's angina occurs due to infection of, so now we know the answer is the submandibular space. It's a rapidly spreading infection of submandibular space. Okay, next question, it's a clinical question, and you can see that this question has been coming repeatedly in different exams. You see, FMG December 17, FMG June 18, December 18, June 19, December 19. So 5 times consecutively this question was asked, repeatedly asked in the same exam. Okay, highest number a question can be repeated 5 times. A 15-year-old boy presented with history of fever. So patient has fever since last 2 days. Okay, he is unable to swallow food. So patient is having dysphagia. So fever, dysphagia, and having muffled voice. So when I say muffled voice, it means hot potato voice, right? On examination, it is noted that right tonsil is shifted to midline. You see, the word used is shifted to midline. It is not said tonsil is enlarged. Okay, it is said tonsil is shifted. So whenever we use this kind of language, it is shifted to midline, it is pushed to midline. That means something is pushing it from behind. Okay, from the lateral aspect. So the answer to this question is parapharyngeal abscess. Okay, now point to note, I had told you at that time also, the muffled voice, this muffled voice or the hot potato voice, I told you at that time also, this is not just found in quinsy, it is found in any acute condition of the pharynx such as quinsy, lateral or parapharyngeal abscess. Okay, or also in case of acute epiglottitis. Right? Okay. Next question. A 7-year-old child presented with quinsy and severe trismus. What will be the next line of management? Very good question. It was asked few years back in the AIMS exam. Okay, and I've kept this question because it's a very, very wonderful question. You see, every word of this question is important. How? Let's see. 7 years old child. I'll break down the question. That's how I always solve it. I always break it down into different parts. So 7-year-old child presents with quinsy and severe trismus. Okay, now my first question is, why the patient of quinsy is having trismus? A patient of quinsy has trismus when this quinsy spreads to parapharyngeal space, and from the parapharyngeal space it goes and involves the medial pterygoid muscle. So that means it has almost also involved the masticator space. And now it will have trismus. Patient has severe trismus. That means less than 1 finger mouth opening, less than 1 finger. Okay, what is the next line of management? So with this knowledge, we come to the options. Intraoral incision and drainage. You see, there is no possibility of intraoral drainage. Why? Because patient is having severe trismus, less than 1 finger mouth opening. Okay, so this option is not possible. Next is IV antibiotics for 48 hours. Now you see, this patient has 3 different space abscess: peritonsillar space, parapharyngeal space, and probably masticator space also. There is severe trismus. Okay, now it is a 7-year-old child with this widespread infection, and this abscess can burst, parapharyngeal space abscess, peritonsillar abscess. They can burst in the pharynx and patient can aspirate and die. Would you like to wait for 48 hours without incision and drainage? No, I would not like. That is like putting my child into risk. Okay, so waiting with just IV antibiotics is endangering the life of the patient. We cannot wait. Okay, now we like to go for external drainage. You see, going for external drainage means you have to give an incision. Okay, you have to give incision on the skin. Then you have to go all across the parotid, the ICA, the IJV, the cranial nerves to reach into the peritonsillar space. Okay, so that will be like going through all the tissues. It will be a big path to drain this abscess. Number 1. Number 2. How will you do the external drainage? He's a 7-year-old child. To make the child stay stable, you have to give general anesthesia. 7-year-old child cannot be operated in local anesthesia. But to give the general anesthesia, you have to intubate the patient. The patient is having severe trismus. Remember, you cannot do oral intubation. Can you do nasal intubation? No. Why? Again, when you try to do nasal intubation, there is an abscess in the pharynx and that can burst. If you do a blind or even a fiber optic in nasal intubation, you can burst the abscess. Okay, so that is not possible. The external drainage is not possible. So what will you do? You will do a tracheostomy. Okay, you will do a tracheostomy. Remember the ABC of emergency management. A is for airway. So patient has come to you with an emergency. You have to first secure the airway. This child's airway is compromised. And how will you secure the airway in this child? You will secure it by doing a tracheostomy. Can you do a tracheostomy without general anesthesia? Yes, you can do. Okay, under sedation, the anesthetist will put the child into sedation and within a few minutes, you can complete the whole tracheostomy. Okay, thereafter, the anesthetist can take over and through this tracheostomy, he can give general anesthesia. So when he gives general anesthesia, he will also give muscle relaxant, and when he gives muscle relaxant, you can open the mouth. Okay, so under general anesthesia, you can also do intraoral incision and drainage. Right? So the first step for management of this patient is going to be tracheostomy. You can proceed further only after doing tracheostomy. Therefore, tracheostomy is the right answer in this question. Okay, tricky question. Very important clinical question. Each and every word is important in this. The answer is tracheostomy in this question. Okay, so that is how we solve the clinical questions. A lot of clinical questions are asked from this topic, and with this knowledge, I am sure you can solve all the different clinical questions asked in this. Thank you.